Hi guys, this is week one, day 4 video for you, so you can watch this on Thursday. It's been a great week. I've seen some real progress in your assignments. I'm real happy with that. You're turning stuff in on time, and it's getting to be more and more complete. We still always have a few things to work on. We're looking for perfection, right? I'll shave one of these days, sorry. Let's see, let me go over a couple things here real quick on the assignment from Wednesday. Let's see, some of the answers here. Most of you did a pretty good job. Body planes. That was probably a poorly worded question there. We were talking mainly about closing cavities. Probably should have put cavities there. I think Evelyn, shout out to Evelyn, she got into body cavities because when the surgeon has completed their whatever they're trying to do, depending on how deeply they've gone into the body, they've got to close everything on the way out. They may have to close up part of an organ. Then they'll have to close up maybe the abdominal cavity. The organs don't just sit there and float around. They're kind of encapsulated in a cavity, which we call, if you look at your anatomy books, it would be more explained to you a little bit better. The abdominal cavity is kind of a tissue layer that kind of holds everything in place. Beyond that, you're going to have muscle tissue if that was cut. Usually they try not to cut muscle tissue. You're going to have a layer of fascia, F-A-S-C-I-A. That's something you don't see in a lot of books, fascia. That's almost like a cellophane covering that just kind of holds everything in place. And sometimes that needs to be sutured back together. You'll also have the skin, layers of the skin, as a lot of you mentioned. So it's not referring to so much as sagittal planes of the body. That's kind of an anatomical location or anatomical plane of the body, sagittal plane, stuff like that. What we're talking about here really in surgery is layers. So plane probably confused you a little bit, so that's okay. Critical duties. Most critical duties of surgical techs, in my opinion, are infection control and preventing retained foreign objects. And there'll be some of this on the assignment that you'll work on tomorrow, Thursday. But retained foreign objects and infection control, those are huge, huge items that a lot of money can be spent in lawsuits if these aren't done correctly. So we'll talk about these more as we go on. Suctioning, sponging, and holding a scope. Some of you got this right, some of you got confused on how the surgeon, all this is about visualization. We're talking about visualization. We're not talking about imagining something. We're talking about the surgeon being able to see. Anytime they're working inside the body, there can be a buildup of blood from leaking vessels. There can be body fluids. Visualization. The surgeon will often say, I need visualization here. Well, that includes sponging of blood, suctioning blood and body fluids. It means using the overhead light, directing the overhead light at an angle that shows down into the body cavity. You'll find in healthcare, in surgery, in medical, there's 3 ways to describe almost everything. So that's why there's so much to learn. You have to learn all the terms. And like I said, there can be 3 that apply to the same thing. Just like with bleeding, there's hemostasis, there's clotting, there's ligating, all those things. Similar thing. How does a surgeon see if you're holding the scope? Well, this was kind of a trick question. I was hoping some of you might run across it, and some of you did. And some of you who work in healthcare already know the surgeon looks on a screen. If there's a scope inside the body, that scope is wired up and projects the image up on a screen, a TV screen, coming down out of the ceiling. That's all it is. The surgeon is looking at the screen, doing their work. You're holding the scope, showing them what they're looking at. That's all that means. Some of you said they looked through the lens of the scope. So we like the laughs. We like to laugh at ourselves. We like to have fun. Let's see, cutting the knot, cutting the suture knot. I think one of you had this poor surgical tech getting fired for cutting a surgical knot. So that's a little bit harsh. That usually doesn't happen. They would have to take a lot more for that to get a tech fired. But the main thing here is the surgeon will get mad because they have to redo it. They have to redo that suture. They have to pull all that suture out and redo it. If you cut the knot, you've just destroyed what they've just done. Because they're suturing layers, they're tying knots, and they're waiting for you to cut it. So we teach you how to cut it so that you don't cut the knot out. You cut the knot out, yeah, they get mad, they call you all kinds of names, and they have to redo it. So the patient is under anesthesia longer, the case lasts another 5 minutes. You know, it's like I said, we're talking about time. Time under anesthesia, blood loss, strain on the heart, all these things. Try to avoid that. We want to be fast, we want to be perfect. Professional competency. Professional competency, some of you gave me a little bit of weak answers on some of those. You should have looked in the book a little bit more. Let's see, professional competency includes a lot. Continuing education, surgical conscience and honesty, respect for the patient, ability to communicate, willingness to serve on committees, consistent attendance, punctuality, patient confidentiality, willingness to learn and to cope with change, knowledge, attitude, values, a whole bunch of stuff in here for professional competency. So some of you needed to push that a little bit harder. Accredited. Yes, Kaiser is accredited by SACS, Southern Association of Colleges, and Southern Association of Colleges, and so on. We also have that accredits Kaiser University, but each program also has its own programmatic accreditation. Nurses have their nursing program has their program accredited by an organization. Surgical techs, we have our program accredited by an organization. Yeah, it's overlap, but SACS, the accreditation of Kaiser, is for the school as a whole. Most of the other programs in healthcare have our own program accreditation. So that's what we're talking about there. KHEP. KHEP is what you should have put there. So you got to dig a little bit. Let's see, number 11. Some of you did not put, most of you did, but a few of you did not put what specialty interests you. So I'm not, when I do questions like that, sometimes I'm not so much interested in what interests you. I'm interested in you following up and answering the question. So you gotta be thorough. You gotta go back and read the questions. What all does it ask for? Because those of you who missed it launched right into the specialties, and by the time you got through with the 14 or so specialties, you didn't remember that you were supposed to indicate which ones you were most interested in. So thoroughness, thoroughness, thoroughness. I'm going to teach you. I'm going to push you to be thorough. More thorough than you've ever been in your life. You're not going to leave any stone unturned. You're going to get it. So that comes with training, dedication, openness on your part to learn. Now just a couple things here on the last part of this chapter 1. I'm not going to get too interested about resume preparation and interview. I think that's all a little premature. I mean, we're just trying to learn what it is we're going to be doing. I really think that should be in the back of the book, but we'll cover it before you leave at some point. Clinical ladder programs, you'll see some of that in here. how you advance. Most hospitals will have some formal way for you to advance. So you go in as an entry-level practitioner where you're new. You've got to learn the ropes. You got to get comfortable. You got to know where things are. You got to learn the surgeons, the nurses. And a lot of this depends on you. How quickly do you learn? How quickly do you adjust? How dedicated are you to moving forward? But that's level one. Level two would be a proficient practitioner. You know what to do. You meet the criteria in level one. You become a good teammate. Your skills and tasks start to get more important, start to add up. And then your level three is an expert practitioner where you know what you're doing. You've done it long enough, you know what you're doing. You pull it off every single time. And that's it's one of the tough things in surgery. You got to focus on every case. Every case is the first time for that patient. You might have done it several times, but it's the first time for that patient. So you can't take a case off. You have to focus, you have to concentrate, you have to get it done. That surgeon has liability for that patient. When you get to that point where you can just turn the switch on and focus and get it done perfectly, then you become an expert practitioner. They pay you more, and they might make you a preceptor for a new Kaiser student. We have preceptors precepting our new Kaiser students, which is kind of cool. So let's see. So that's that. Confidentiality. We always maintain confidentiality with patient. We don't talk about stuff in the elevators. We don't talk about stuff on the way to the break room. You might be passing by a family member. They may hear you. They may realize it's their loved one that you're talking about. So you get into huge trouble. So confidentiality has to be maintained, and you'll learn that. Teamwork and communication. There's some stuff in your assignment for Thursday on teamwork and communication, how to deal with conflict. There will be conflict. Just like there's conflict in your family, there's conflict in school, there's conflict on your jobs. There's always conflict. The question is, how do you deal with it? How do you handle it? Do you deal with it calmly? Do you turn it around into something positive, or do you make it something bigger than it never should have been? There's always somebody in an OR team that likes to be the drama queen, or the drama person, drama guy. Most people, in my opinion, like that want attention, and they think that the best attention they can get is when they're complaining. Otherwise, nobody gives them attention. So people complain a lot in the OR. They complain a lot everywhere, but and some of it's for fun. But when it gets out of hand, or when people start getting on each other's nerves, then somebody has to be calm. Somebody has to diffuse it. Somebody has to make people laugh. That's why if you got a good sense of humor, you're going to have to use it, because people deal with enough. We deal with enough demanding surgeons. We deal with enough blood and gore, heavy work schedules. If you can make people laugh in any situation, then you're way ahead. People are going to want you in every room. But there's ways to deal with conflict. You can see that in the book. Let's see, what else? Teamwork. Teamwork is huge. You think you have a family at home, you're going to have a family in the OR. You're going to be spending so much time with these people in the OR under, life-threatening conditions for patients that you'll form some of the closest friendships you'll ever have, because no one has seen what you've seen. No one experiences what you've experienced. And anytime you get into a situation where you're just like, wow, I've never seen this before. This is so This is so crushing. This is so intimidating. This is scary. Embrace it. It's in how you react. Embrace it and say thank you to yourself. Thank you for giving me this opportunity, because this builds my experience base, and so that I can, I can be a preceptor for the new student that comes behind me and say, this is the way you handle this stuff. No problem. We still get the job done, no matter what happens. That's all teamwork and how you deal with things. We look for problem solvers. We look for critical thinkers. There's some more information here on communication about sender, message, receiver, feedback, all that good stuff. The point I'd like to make about that is, and this is true with your families, it's true with your work, it's true with your life. If somebody asks you or tells you to do something and you do the wrong thing, it's not really their fault. It's your fault because you didn't clarify. If I give you an assignment and you don't understand it, and you turn something in that's not right, it's not my fault. It's my fault because maybe I didn't write it too well. But why didn't you ask me to clarify? See, take responsibility. That's what a great surgical tech does. They take responsibility for getting it done right. Then you've got a pro. Somebody asks you to go get something you don't quite understand, well, you clarify. Restate what they just said, what you thought they just said. Is that what you said? And they'll say, no, that's not what I meant. I said this. So clarify before you go get something that somebody wants, or before you do something somebody wants you to do. Always clarify. You've got to learn to communicate. Somebody said they were shy. That's okay. We've got shy people in the OR. We've got quiet people in the OR. We've got noisy people and loud people in the OR. We've got gregarious, outgoing people. That's the beauty of the OR. All kinds of personalities. They act crazy sometimes, but the bottom line is they get the job done and they get it right. So that's all something that you learn how to deal with. Bottom line is get the patient out of there and get them out of there safely. There's a lot of other stuff in this rest of this chapter on hospital departments, financial considerations, reimbursement. Like I don't know why HMOs, PPOs, insurance. Not something we really deal with. I'm not going to worry too much about that. Professional organizations. There's a professional organization for everybody. Surgeons, anesthesia people, infection control people, nurses, SPD, everybody, like I said. So you can read through some of that. You know what our organizations are, AST, and so forth. The Joint Commission, I think maybe most people have heard of the Joint Commission before. They accredit healthcare organizations on a volunteer basis, and hospitals like to say we're accredited by the Joint Commission. It's just another something they can use to market themselves as meeting certain standards. Although even that has issues. As a matter of fact, Google All Children's Hospital in St. Petersburg, Florida. Accredited by the Joint Commission. 13 pediatric patients died at that hospital over a 3-year span. I think it was 2012 to 2015 or something like that. They got some bad management in there, got some bad surgeons. Staff were reporting problems. It's just a bad situation. But it took 13 deaths, and somebody contacted the Tampa Bay Times, who wrote a big expose on All Children's Hospital for that to come to light. And then all of a sudden, the agencies that were responsible for overseeing stuff all decided to come down and take care of it. Too bad for those 13 kids. So accreditation is nice, and certification, Joint Commission, all that stuff is nice. What it really gets down to is who are you? How honest are you? What kind of person are you? Are you interested in getting it done right? Or are you going to look the other way and go home? That's not what we want. I think I missed something in here. Was it surgical conscience? Yeah, surgical conscience. The best definition I can give you of surgical conscience is you do the right thing no matter what. Even though you know it's going to take another 30 minutes, it's going to cause everybody to stay around, you point out what is right and true and proper, and we've got to get this done before we can close out this case. In other words, maybe the count. If the count doesn't add up, we've got to get it right. And most places are good about this. I guess let me expound on that a little bit. The surgical conscience is going to come into play mostly when you're in the room by yourself, because you will be in the OR room eventually, not as a clinical student mostly, but eventually you'll be in the room by yourself setting up the case. And of course you have to observe sterile technique. You can't contaminate anything because it's all translates into patient safety when the case gets started. If you were to get careless, make an accident, or make a mistake, and contaminate some item that is supposed to go on the sterile back table, you have to admit it and correct it, even if nobody's watching. Then that's where you're going to find out what your surgical conscience is, and that's where we depend on you to do it the right way. Nobody saw it. You could easily stick it back up on the table, not tell anybody, nobody would know. Well, how do you sleep that night? Wondering if there's some type of bacteria that's going to make its way into that patient because you contaminated something. You don't want to do that. That's why I've said before, we respect people who admit their mistakes more so, because we know they don't have to. If somebody admits they made a mistake when they know nobody was looking and they don't have to, then that's when our respect for them goes sky high. We know we can depend on them. And that's what we've got to do in surgery. We've got to depend on people to do the right thing. There's no ifs, ands, or buts. No is, maybe, or whatever. It either is or it isn't. It's either sterile or it's not sterile. And that's where the surgical technologist comes into play when they're setting up a room and opening up supplies onto a back table. It has to be done a certain way. Things have to be kept sterile, and that keeps everybody safe, especially the patient, especially us. Okay? So I think that we'll sort of finish up chapter 1 here for us. Again, I'll have an assignment for you to do tomorrow. Everybody's doing pretty well. So if you have any questions, let me know through text or email. But proud of the work you've done so far this week. The main thing is everybody's been real cooperative, because I'm here to tell you what you need to do. Okay? So you've been very cooperative. I appreciate that. Make my life easy. And we'll see you tomorrow.